So in this lecture, we will be discussing the beta-lactams antibiotics. And by the end of this lecture, you will be able to describe the structure of the structure differences between different beta-lactamases, recognize the different subclasses of this beta-lactams, mechanism, indication, and adverse effects of these beta-lactams. So you can see that beta-lactams belong to the cell wall synthesis inhibitor. So all of these beta-lactams are causing the inhibition of cell wall bacterial cells. And they are called beta-lactams because they have this beta-lactam in their structure. So this beta-lactam ring is the common in all these penicillins, cephalosporins, carbapenems, and monobactams. We also have vancomycin, which is also a cell wall synthesis inhibitor, but it doesn't belong to this beta-lactam class of drugs. So in this lecture, we will be discussing this beta-lactam drugs. These are the first and most diverse commonly used classes of antibiotics, and they have several mechanisms of actions. They inhibit cell wall synthesis by irreversibly inhibiting the transpeptidase enzyme. Basically, this transpeptidase enzyme is responsible for the synthesis of peptidoglycan layer, which is composed of this many peptidoglycan polymers. So this enzyme is also called penicillin binding protein enzyme. It is causing the formation of peptidoglycan layers, which is the main component of bacterial cell wall that we have discussed in the structure of bacteria in the introduction to bacteria class. So here, mostly these cell wall synthesis inhibitor, they are bactericidal. Other mechanisms through which this beta-lactam work is the activation of autolytic enzyme, autolysins, which causes further lysis of the bacterial cell. Also, these penicillins inactivate the enzymes which are located on the bacterial cell membranes, and they are involved in the synthesis of cell wall. So they are called protein binding proteins, and these beta-lactams inhibit these protein binding proteins and then inhibit the synthesis of cell wall. Generally, these cell wall synthesis inhibitors, these are bactericidal. This is the classification of beta-lactams, and you can see here that they are further classified, like penicillin, cephalosporins, carbapenems, and monobactams are the main classes of these beta-lactams, which are further classified into subclasses. Like penicillins are subclassified into natural penicillin, anti-staphylococcal penicillins, they are effective against only the staphylococcus bacterium. Natural penicillins, they have less short half-life. Then we have extended spectrum and penicillins. They are more, these two are normally narrow spectrum penicillins, but this is extended spectrum like ampicillins and amoxicillins. They are extended spectrum penicillins, and pseudomonal penicillins, these are the active against pseudomonal species. But after that, we will discuss cephalosporins with their classification, and carbapenems and monobactams. Therapeutically, penicillins are very important, and they are the first choice for many bacterial infections. And normally they are started empirically based on the symptoms. A penicillin therapy is started without the proper pathological identification of the organisms. Clinical uses of penicillin G, this normal penicillin, it includes the bacterial infection caused like endocarditis, pharyngitis, gonorrhea, syphilis. These are different types of bacterial infections. Intravenous penicillin G is among the antibiotic of first choice for the therapy of meningitis caused by susceptible Staphylococcus pneumoniae. An indication for nepsillins or amoxicillins apparently include severe staphylococcal infection like endocarditis or pneumonia. These extended spectrum penicillins like ampicillin, which belong to which have extended spectrum penicillins, they are the drug of choice for meningitis caused by Listeria monocytogenes. Amoxicillin oral therapy is used for otitis media, bronchitis, sinusitis, well, amoxicillin is also used for the eradication of H. pylori in the duodenal and gastric ulcer. So you will discuss this in the gastric ulcer. This H. pylori is also one of the common or most common cause of gastric and duodenal ulcer. Anti-pseudomonal species like ticarcillins or piperacillins, they are used for the serious infections caused by pseudomonal or zoonosa. Now, pharmacokinetics varies for different types of penicillins. So that's why if we start from the absorption, the oral absorption of various penicillins varies according to the particular penicillin used. So every one of them has a different bioavailability. pH of the stomach is important because these drugs are destroyed by the gastric pH. So if you are taking the food, these drugs will take more time in the stomach, and then the gastric pH will destroy most of these drugs. That's why most of these penicillins should be used without be given without food to enhance absorption and to decrease its degradation in the stomach. The exception is amoxicillin and penicillin V. Penicillin are widely distributed in the body fluids and across the placenta. However, none of the beta-lactam has shown to be teratogenic, so they don't have any teratogenic effect on the fetus. However, they can enter the cerebrospinal fluid in case of inflammation. So during inflammations, the blood vessels are dilated and they are more permeable. So during inflammation of the meninges, the drug can cross this meninges and enter the cerebrospinal fluid. But without inflammation, their entrance to the cerebrospinal fluid is minimal. They are metabolized by the hepatic enzyme and excreted through the kidney route. So that's why dose adjustment is needed in case of hepatic problem or if a patient who have renal problems. All penicillin except staphylococcal penicillins require dose adjustment in renal failure. So in renal failure or hepatic failure, dose adjustment is needed. But except this anti-staphylococcus, where the main route of elimination is not kidney, that's why they might not need dose adjustment in case of renal problem, but all others do need dose adjustment. Now, how bacteria can evolve resistance to penicillin. So remember, we have discussed the beta-lactam ring. That's the main component in all that beta-lactams antibiotics. So what these bacteria can do, they can produce beta-lactamase enzyme, and they break down this beta-lactam ring in the penicillin. So breaking down this beta-lactam ring causes the inactivation of these antibiotics. So this is one of the mechanisms through which they can evolve resistance. The other is decreased permeability. So it can decrease the penicillin's penetration to the target site. So if the permeability is decreased, the drug cannot enter to its site of action, then the drug becomes inactive. Another is inability of penicillin to bind its protein binding proteins. Remember, we have discussed that these protein binding proteins are responsible for the synthesis of bacterial cells, and they are inhibited by the beta-lactams like penicillins. So they can evolve or mutate this penicillin binding protein, and the drug or the penicillin is then unable to bind to their main site. And lack of activation of autolytic enzymes. So all the mechanisms through which these penicillins act, these bacteria can evolve resistance to that by changing that process. So then the beta-lactam will be unable to activate that autolysin. So as we have discussed, these beta-lactamases, they are diverse group of enzymes which cleaves the beta-lactam rings, inactivating the beta-lactam structures. So this is most commonly present in the gram-negative bacteria, and that's why gram-negative bacteria can evolve resistance to these penicillin more frequently as compared to gram-positive bacteria. Some penicillins are combined with beta-lactamase inhibitors, which can irreversibly inactivate the beta-lactamases. So now, in order to inhibit this production or the action of these beta-lactamases, some penicillins are combined with the drugs which inactivate this beta-lactamase. So you are inactivating this beta-lactamases, and then penicillin can be effective in those bacteria which can produce this beta-lactamase enzyme. So these are the examples where the penicillin are combined with beta-lactamase inhibitors, and they are very much effective. Augmentin is the main drug in this class, and they combine amoxicillins with clavulanic acid. So clavulanic acid is the inhibitor of beta-lactamase, and it prevents the bacteria to inactivate this amoxicillin. In the other examples are unosine and zosine. So they combine penicillins, ampicillins with sulbactam, and piperacillin with tazobactam. So these are the beta-lactamase inhibitors, and these are the penicillins. Adverse effects include hypersensitivity. Some patients are sensitive to penicillin, so that's why if the patient is taking these penicillins for the first time, then they are given the first test dose in order to see if they can develop the hypersensitivity reactions or not. Along with that, it can produce the diarrhea, nephritis, or neurotoxicity if injected intrathecally into the spinal cord. Hematological toxicity that can decrease the agglutination may be observed with penicillin G. So it can decrease the coagulation or agglutination of the blood. The second class in this beta-lactam is cephalosporins, and they are derived from the fungus Cephalosporium acromonium. They are the second choice for many infections. They are effective against gram-positive and gram-negative bacteria. Oral drug like cefaclor are used in urinary tract infections, and they have 5 generations, each effective against a broad spectrum of bacteria. About 10% of the people who are allergic to penicillins also allergic to cephalosporin. So these drug, this is cephalosporin, and they also have this beta-lactam ring, and they are divided into a different generation based on their activity. So every generation, like the second generation, third generation, fourth generations, they have some beneficial effect as compared to the previous generation. So they are either more effective or less harmful than the previous generation. That's why the 5th generation of cephalosporins are based primarily on the spectrum of antibacterial activity. So every other generation, every next generation has a wider spectrum or more specific, more safety than the previous generation. The basis for so they are based on the spectrum of bacterial activity, or the basis or on the basis of antimicrobial activity, including beta-lactamase stability and pharmacological properties. So generation wise, from first to fourth or fifth even, the spectrum of activity against gram-negative organisms and the stability against gram beta-lactamases increases, because mostly these beta-lactams are more effective in the gram-positive bacteria as compared to gram-negative bacteria, because gram-negative have more beta-lactamase enzyme, so they are more stable against these. They are more stable against this beta-lactamase enzymes, the next generation. And they have same or reduced spectrum of activity against gram-positive organisms and pharmacokinetic differences. The fifth generation drug has more activity against gram-positive and most of the gram-negative bacteria. The second and fifth generation are effective against the anaerobic bacteria. This ceftazidime, cefepime, and ceftolozane, the third, fourth, and fifth generations, they have 80 pseudomonal activity. So this ceftolozane, it is more potent than the ceftazidime, which is a third generation, and this is derived from this third generation drug. So it has more effective, or it has more potent than this third generation drug. The only cephalosporin for MRSA is this ceftaroline. So it's also a fifth generation drug, and it's the only one in this cephalosporin which is effective against methicillin resistant Staphylococcus aureus, which is a superbug. We have discussed this in the introduction to antibiotics drug. So these MRSA have developed resistance to most of these cephalosporins. That's why next generations drugs are discovered in order to have better spectrum against these resistant bacteria as well. Absorptions, they have good oral absorption. The absorption of most of these cephalosporins is unaffected by the presence of food except the cefradine or cefaclor, for which it may be delayed. Distribution very well into the most of the body tissues and fluids, including the bone, pleural fluids, pericardial fluid, and synovial fluid. So it has a wide distribution. All cephalosporins except ceftriaxone and ceforazones are required dose adjustment in renal failure. So most of them, these drugs do not require this dose adjustment in the renal failure, but all of them are requiring the dose adjustment because they are excreted through the renal route. The adverse effects, cephalosporins produce a number of adverse effects, some of which may be unique to particular member of the group. Allergic manifestation is the main one of the common side effects, like patients who have had an anaphylactic response to penicillin. That's why they should not receive cephalosporins. So first that has to be tested. Bleeding is one of the most common side effects because it has anti-vitamin K effect, and remember we have discussed vitamin K is responsible for blood coagulation. So because of its anti-vitamin K effect, it can cause bleeding. So carbapenems and monobactams were developed to deal with the beta-lactamase producing gram-negative bacteria because they were resistant to penicillin by producing this beta-lactamase enzyme. So carbapenems, the main example is imipenem. It's a broad-spectrum antibiotic, and it is widely distributed. It is normally given intravenously, and when it's given intravenously, it goes into the kidney where it is metabolized or where it is biotransformed with the help of enzyme which is called a dehydropeptidase, and it is converted to a toxic metabolite that causes nephrotoxicity. So in order to inhibit its biotransformation in the kidney, this imipenem is combine with cilastatin, and cilastatin inhibits its biotransformation in the kidney to inactive or toxic metabolites. This drug is not absorbed orally, that's why it is given intravenously. And for the renal tract infection, this drug has to be combined with cilastatin that we already have discussed that. Cilastatin inhibits the dehydropeptidase enzyme, which causes the degradation of this drug in the brush border of the proximal renal tubule. So for a urinary tract infection, if you combine this drug with cilastatin, this drug will remain in the active form in the renal region for urinary tract infection. So the drug is hydrolyzed rapidly by dehydropeptidase to inactive metabolites found in the brush border of the proximal renal tubules. Because the active drug concentration and the urine becomes very low, and then it cannot be effective in the renal tract infection, especially bacterial infection. That's why cilastatin, which is dehydropeptidase inhibitor, was synthesized and combined in equal amount with imipenem in order to have higher concentration in the urinary tract for urinary tract infection. 70% of the imipenem if given in the combination with cilastatin is recovered as active drug in the urine. So it doesn't go more metabolism in the liver. So it's excreted as such from the kidney. Doses should be modified in case of renal insufficiency because it is excreted through renal route, so that's why the dose has to be modified. Carbapenems can cause seizures. This is one of the side effects. Ertapenem and meropenem do not require addition of cilastatin because they are not degraded by this dihydropeptidase enzyme. Monobactam astronome is active only against gram-negative anaerobic bacteria, and they are resistant to most of the beta-lactamases. That's why they are effective against these gram-negative anaerobic bacteria. So that was all about the cell wall synthesis inhibitor, where we have discussed these beta-lactam drugs, including penicillin and cephalosporin is the main class, or a most widely used drug against most of the gram-positive bacteria, along with others, and carbapenems and monobactam.